So we are live.
Hello and welcome to this webinar. I hope this is a wonderful time for everyone. We're here at the Health Watch 2.0. And the Health Watch, this is the second edition. The first one was during the year of COVID and focused on virology and quite a number of things. So you can see that Philips HMO, they're really trying to ensure that you are well informed about your health. And because sometimes we just think that, the only benefit is money. Sometimes it's not just money. Education and information is also valuable. We have a lot of speakers lined up, a lot of interesting topics, versions of a particular topic, because we are focusing on chronic kidney diseases from prevention all the way to transplantation. If you have questions, if you have comments, if you have, issues that have been troubling you about your kidney, because I actually think that the kidney is one of the very most important, organs in the body. I call it the loma of the body. Waste takes it out, because once there's a problem with the kidney, you start to see, the issues almost immediately. So please welcome. I can see there are quite a number of us here. Welcome. If there's someone near you that has not signed up, please send them a reminder that they should not miss this important meeting. Before we start, let us first of all obey the laws of the land in which we're in. Yes, it's virtual, but it's not still virtual like that. We're still in Nigeria, for those of us, majorly in Nigeria. So please, we will take a few moments to sing the national anthem. So wherever you are, if you are sitting, standing, let's just use 1 minute, 2 minutes to sing the national anthem and get this meeting to a start. Thank you for waiting for us. And national anthem, here we go. Thank you so much for that. One of the most important lines for me, I don't know about you, in that particular anthem is the labors of our heroes past shall never be in vain. We've actually come a great way as a nation, and, it's showing in quite a number of organizations that are sprung up in this country, Philips HMO being one of them. So to get right into it so that we don't waste your time, we're going to have a welcome address by Dr. Folu. I call her Dr. Folu, she's more like an elder sister to me. So Dr. Folu will give us a welcome address and let us know exactly why we're here, somewhat to expect, and she'll be the referee to blow the opening whistle for this particular match. Dr. Fulum, please, you have the
Good
floor.
morning, everyone, or it's
Good
already
morning.
afternoon. Good afternoon, everyone.
Ah,
Thank you. Good afternoon, everyone. It's a pleasure to welcome you all to the webinar of all webinars today. This is Health Watch 2.0, and on behalf of the chairman of the Philips Group, Mr. Folusha Phillips, the MD of Philips HMO, Dr. Victor Benebo, and all members of Philips HMO, all staff of Philips HMO, we bid you a warm welcome to today's webinar. Philips HMO happens to be the baby of the become synonymous with excellence. And in keeping with that, we have started our own excellent tradition of bringing topical medical issues to the public space for discussion by the experts. We want to dispel myths and misinformation to ensure that our clients and the general public is well armed to prepare for whatever medical challenges they may have. And indeed, preventive care is our focus as well. Health Watch 1.0, as Apropos Doctor has alluded to, was COVID related. And in that webinar, we had two of the brightest minds in medicine today in Nigeria talking to us about the next pandemic and how to prepare for it, and also the challenges of dealing with the mental health strain that came from the pandemic and how we had to adjust, from, to the changes of the pandemic. So today I'm promising you nothing less than the best from the team of experts we have been able to put together. Um, I hope you'll stay with us till the very end. It promises to be a wonderful time. So I think my work is done. I'm going to hand you right back to Apropos Doctor to get this show on the road. Thank you so much.
thank you, Dr. Folu. There are a couple of things you said that puts quite some fire in my, in my body, and one of them was, this is the webinar of all webinars. This is quite a webinar that is very, very, very instructive. And the reason is, when it comes to chronic kidney diseases, quite a number of us, especially as Nigerians, are falling at risk of it, be it from our practices, to medication, to toxins out there. But I'm sure that our speakers that are lined up are going to do justice to it. If you are on this particular webinar, please, I want you to pay attention to the end. Pay attention for a couple of reasons. Number one is because this particular information is going to benefit you. Somebody's already saying health is wealth. I agree. Another reason is because, there will also be interactions. There's opportunity for you to ask questions. So if one of the speakers says something that really resonates with you and you want to know more about it, use the chat box. We will be able to get to your questions as quickly as possible. And then lastly, there's going to be some major giveaways going on. So make sure you listen, make sure you pay attention. The more you do, the better chances you have at winning our giveaway at the end. From data to, a HMO plan. Please, is even me that wants to win that HMO plan. I don't know about you people. So let's go straight into our first speaker. Our first speaker is Dr. Titilayo Elore. She's, quite armed. She comes with an armament of qualifications. And I think she's more than qualified to be able to give her opinion and give and educate us about chronic kidney diseases, especially, as Africans. But before that, we'll play something for you to know exactly who Dr. Titilayo Elore is and why she's on this space. So,
Dr. Ilori is a product of three continents. She completed medical school at the University of Lagos, Nigeria, and then moved to the UK for a research internship at the University of Manchester, where she worked in population-based nutritional epidemiology. She then moved to the US, where she completed medical school at the Morehouse School of Medicine in Atlanta, followed by a fellowship in nephrology at Emory University. As a fellow, she received the National Kidney Foundation Young Investigator Award and the Southern University of Clinical Investigators Young Investigator Award. She has worked within various cohorts in the US and Sub-Saharan Africa, including the All of Us Research Program and the Human Hereditary and Health in Africa Kidney Disease Research Network as a co-investigator. She's an assistant professor at Boston University School of Medicine, where she sees patients, teaches fellows, and conducts research. She's co-chair of the Regards Kidney Working Group and has spoken at many national and international conferences. She has a passion for mentoring and training other physicians, especially women and those from underrepresented backgrounds.
So, Tetila Ilori, thank you for taking time out to be with us. You have the floor.
Thank you so much for that very humbling introduction. Okay. I just need confirmation you can see my large screen.
Yes, we can.
All right, great. So, Black individuals in the US suffer from kidney disease at a rate that's 3 to 4 times higher than white individuals. The excess burden of kidney disease extends to other Black individuals, especially the over 1 billion people living in Sub-Saharan Africa. My name is Titi Ilori. I'm a physician. I see patients, and I also do a lot of clinical research. And I've come to this point in my career because I've seen the devastating burden of kidney disease, both in Sub-Saharan Africa and all over the world. The title of my talk today is Chronic Kidney Disease in Sub-Saharan Africa, Clinical Factors, Gene-Environment Interactions, and Social Determinants of Health. These are some of the objectives of today's talk. And I'm going to start my talk somewhere in rural Nigeria in early 2000 when I was doing my internship. There was a 37-year-old male who lived in Germany who had come back home to Nigeria to marry his fiancée. He had had some chronic illness, but he started becoming more ill, had loss of appetite, reduced urine output, rash, itching. He was rushed to the local hospital, and his creatinine, which is the measure of his kidney function, was 10. His BUN, another measure of kidney function or breakdown of urea, was 120, normal being less than 1 for the creatinine. The decision was made to start dialysis at the time. He had no family history of kidney disease. He had no hypertension. He had various symptoms, including loss of appetite. Hemodialysis was planned, but because there was only one dialysis machine in the area, people, we were limited on how fast we could start dialysis, especially when his blood test came out as HIV positive. And at that point, no one wanted to risk using the only machine in the area for someone that was HIV positive. And so the plans was made for peritoneal dialysis or dialysis through his stomach. We got the surgeon, we got everything ready, we had everything imported. But unfortunately, he continued to get worse before the surgery. He went into uremic encephalopathy. And I remember that patient coding and calling my name and the rest of the medical team for help as he passed away. That made a solid impression on me. And that was one of the reasons why I went into nephrology. So what is going on right now? There are disparities, severe disparities in the prevalence of chronic kidney disease, especially in Black people. These are some of the numbers I will share with you 3 times. Chronic kidney disease is 3 times higher in Black Americans than white Americans, 4 times. The lifetime risk of end-stage kidney disease, which is the final continuum of kidney disease where dialysis or transplantation is needed, is 4-fold higher in Black Americans compared to non-Hispanic white Americans. And 10 years, the median age of onset of chronic kidney disease is 10 years earlier in Black Americans compared to white Americans. Chronic kidney disease attributable to diabetes is almost 12-fold higher in Black people. Prevalence of diabetes is almost 2-fold higher in Black individuals compared to white individuals. And obesity, which is one of the risk factors of kidney disease, is 1.5 times higher in Black Americans compared to white Americans. Let's come down to where we are. What are the disparities of chronic kidney disease in Africa? There is an aggressive chronic kidney disease form that exists in sub-Saharan Africa because kidney failure here occurs at 20 years earlier than in the Western world. 6 to 8%. There's an alarming rise in the annual incidence of kidney failure or end-stage kidney disease in sub-Saharan Africa at the rate of 6 to 8% per year. And 33%, about a third of all the diabetes patients in Africa will have kidney failure after 5 years. Some of these are very alarming statistics. This was a paper we did in 2017 that showed that the prevalence of chronic kidney disease is actually highest in Western Africa, almost 19.8%. And I think our data continues to grow. And when you look at subsets of kidney disease, like what about populations that have hypertension or diabetes or HIV, your prevalence of kidney disease may go as high as 83%, as seen in this paper in Tanzania. So, and this is my little attempt at AI imaging, chronic kidney disease really may be a death sentence in sub-Saharan Africa. And that's part of what we're trying to fix by some of the issues we're discussing today. When you look at the risk factors for CKD, if you look at the highest prevalence of obesity, obesity has, the second highest prevalence of obesity is in Western Africa, and that's where the highest prevalence of chronic kidney disease is as well. And this paper we did within an African cohort in Nigeria and Ghana, looking at about 8,000 individuals. And we found that of individuals with and without kidney disease, the prevalence of the risk factors for kidney disease were extremely high. 52% of people had hypertension, 20% of people had diabetes, and about 10% had elevated cholesterol. And the odds or risk of kidney disease was higher in those with hypertension, older age, and higher BMI, and almost twice as high in those that had elevated cholesterol. But the issue, I think, is not just in the tissue. The issue may also be in the genetics. So recent research has shown us that a genetic variant exists called the apolipoprotein A1, and I know that's a mouthful, so I'll call it ApoL1. The ApoL1 gene, which is located on the short arm of chromosome 22. This gene is produced in the liver, circulates with HDL, and there are two variants of this gene, the G1 and G2. And together, these two variants that were discovered in 2010 explain more than 70% of the excess risk of kidney disease seen in Black individuals, thus making the ApoL1 risk variant the strongest genetic risk factor for kidney disease that has ever existed, and the most powerful genetic risk variant that has ever been identified. But not all individuals who have this ApoL1 risk variants develop chronic kidney disease or progress. And this shows that there may be some second hits which act on a background of the ApoL1 gene variant, causing a gene to gene or a gene to environment interaction, acting on that background, causing this, triggering kidney disease in individuals that have two risk variants. And some of the second hits that have been discovered include interferon, as well as HIV that our patient had, which today is actually the strongest correlate for kidney disease in individuals with the ApoL1 risk variants. We're going to go to another case study of an African with a kidney disease called focal segmental glomerulosclerosis. Don't be scared by the name. So this is a 15-year-old boy who presented to a university hospital in West Africa because he had protein in his urine and his creatinine was rising. His renal biopsy showed scarring and segmental destruction, which we called FSGS, and he was unresponsive to medication. His kidney function continued to deteriorate. He started hemodialysis. His family continued to pay out of pocket. And his father now started workup to be his transplant donor. This was during COVID. What was very interesting, 6 months later, his younger brother presented with the same proteinuria of 2.5 grams, which is a high magnitude. So the physician now requested genetic testing on the father who wanted to be the donor and the other brother in preparation of kidney transplant. The father's pre-transplant workup actually showed proteinuria and high blood pressure. And I'll tell you more about this case later. So this APOL1 risk variant is actually thought to be the reason for this aggressive form of kidney disease that we see in Black individuals. It's also associated with FSGS. And this was formerly called, we thought everybody had this hypertension, the cause of kidney disease was hypertension, and we called it hypertension attributable kidney failure. But recent research has showed that this APOL1 risk variant may be what was responsible. And we think that about some point 10,000 years ago, this species arose in sub-Saharan Africa. And what is interesting is that they were trying to protect individuals. So the APOL1 protein exists because it protects individuals from the lethal sleeping sickness. So we think that at some point 10,000 years ago, 2 trypanosome species evolved in Africa because they were trying to protect individuals from sleeping sickness. However, these variants now predispose people to kidney disease. The parasites are transmitted by the tsetse fly and of course are responsible for trypanosomiasis or African sleeping sickness. So what's really happening here is that individuals that have the wild type of the APOL1 cannot fight the trypanosome. So let me go to this slide. Yeah. So in certain variants of trypanosome, like Rhodiense, individuals that have the normal APOL1 cannot fight it. So the parasite remains and the individual develops sleeping sickness. But those that have either one copy of the risk variants, which is G1 or G2, are actually resistant to the death of the resistant to the trypanosome, and it causes this lysosomal swelling and the parasite dies. So in trying to protect individuals from sleeping sickness, this APOL1 risk variant end up predisposing to kidney disease. And this is some of the data we have now. I think there's new data coming up about the prevalence of the G1 and G2. You can see that in the US, African Americans have a prevalence of 10 to 15% of 2 risk variants and 37% of 1 risk variant. But look at these numbers in West Africa. This is alarming, almost 3 or 4 times. This is what we think is going on. And East Africans who are from a different genetic makeup, it's 0 to 16% of the G1 or G2 variant. And European Americans have no copies of this risk variants. So in summary, in Black individuals, the chronic kidney disease may be inherited by 2 genes, either G1 or G2. And the high risk status, meaning having 2 copies of the risk variant, predisposes individuals to kidney disease, but the low risk variant, which is having 1 copy or no copy of the risk of the risk variant, have the same risk as kidney disease. But some of the research is coming up and saying maybe there's even a problem with having higher blood pressure if you have 1 copy of the risk variant. So the APOL1 risk allele is associated with a range of kidney disease. Individuals with 2 copies of the risk variants have 29 times the risk of developing HIV, 17 times the risk of developing FSGS, 7.3 times the risk of developing non-diabetic end-stage kidney disease, and you can see the remaining risk. So it cuts across the different types of kidney disease. And this landmark paper in the New England Journal of Medicine shows that if an individual has 2 copies of the risk variant, they are almost twice as likely to progress. Look at the person with 2 copies, progressing and declining in kidney function compared to the person with 0 or 1 copies. They also have worse proteinuria as well. So, as I said before, gene and environment interactions refer to the interplay between the genes and the environment in which we live. The genes are the biological instruction determining our physical traits, our eye color, our hair type. And the environment include all external factors that affect us: diet, stress, pollution, and the way our genes interact with the environment can have significant impact on our health. So some people may have a genetic predisposition to CKD, but whether or not they actually develop the condition depends on lifestyle choices, their environment, their diet, their exercise, where they live. So this just really shows the interplay. What was very interesting about the COVID pandemic was that COVID was actually another environmental interaction for the APOL1 risk variant. So when we saw patients that had very bad COVID, developing kidney failure, having to go on dialysis, many of them were biopsied or they did their their genotyping later on. We found out that this patient had 2 copies of the risk variants as well. So more to come on that. So back to our case. Unfortunately, our patient, the 15-year-old died because of irregular dialysis and fluid overload. They did the genotyping of the father, and they found out that he had 2 copies of the risk variant. The younger brother also had 2 copies of the risk variant. They couldn't genotype the patient because he passed away. More looking at kidney failure on the continent of Africa. We know there are delayed nephrology referrals because it's somewhat of a silent disease. People don't know that they have it. There are lower rates of access for dialysis, such as this arteriovenous fistula. And then where are we with home dialysis in Africa? Are people even able to do dialysis at home at their convenience? When we look at the distribution of dialysis centers in a country like Senegal, even though dialysis is free in Senegal, there's only 1 peritoneal dialysis center that's home, where people can do home dialysis. And I'm not sure they're even able to do it at home. But this is the entire country of Senegal, and look at the distribution of dialysis centers. I dare say Nigeria is really leading the way in the number of dialysis centers and even the number of nephrologists. One of my visits to Ethiopia found that there were very few nephrology specialists in the entire country serving the whole population. Nigeria, we have about 17 per million people on dialysis, not because there are no more people that qualify, probably because most people cannot afford it. But about 90% of these are hospital-based units, 10% are freestanding. And I think what it may be sad is that the median survival of people on dialysis is just about 1 month. We definitely need to do better, but we are leading the way and probably could be an inspiration for some other African countries. There's a lot to learn from us. This is a paper by some of my teachers and mentors in the field, Dr. Okoye and Dr. Mambin. The average cost of a dialysis session in Nigeria is about $40,000. And when you consider that the minimum wage is about $30,000, this is a huge burden. A tunnel dialysis catheter costs about $80,000. A temporary catheter costs about $25,000. And the surgery is for the fistula placement, which I show here, is about $150,000 to $300,000. So a lot more needs to be done, considering that you need dialysis 3 times a week. Just a plug in here for, more, this is a study, this is a review we did in Seminars of Nephrology. We really do need more genetic studies in sub-Saharan Africa, because 80% of the GWAS done all over the world in kidney disease 80% are from white populations, and we only have about 5% representation from low and middle income countries. And this is really huge in terms of precision medicine, designing therapies to fit genetic predisposition. There's not enough representations of Africa in these GWAS studies. I'm going to switch gears and just talk a little bit about social determinants of health. The conditions in which people grow, are born, they live, they work, they age, all affect health. The distribution of money affects health. So it's not just in prescribing a pill or prescribing dialysis or prescribing treatment for kidney disease. Where are we sending patients back to? Because the entire environment, the state of mind of the person completely affects health. Genetic factors, social factors, decisions not to smoke, to be physically active, to be exercise, individual choices and behavior, and spending time learning about what you can do to improve your individual choices and behavior, aside from genetic risk, aside from clinical risk factors, becomes super important. I'm just going to talk that it's a complex situation, right? It's not just the clinical factors affecting health. There's socioeconomic status, there's your social support, there's health, housing quality, environmental toxins, air pollution. And a little beacon of hope, the Vertex Pharmaceuticals is actually testing a drug that may be able to treat individuals that have these 2 APOL1 risk variants and kidney disease. So there's more to come on that. In conclusion, I'll say that chronic kidney disease disproportionately affects Black individuals in sub-Saharan Africa and globally. Treating hypertension, diabetes, and obesity may reduce the risk of kidney disease. Apart from these clinical factors, social determinants of health, where you live, work, and play, affects chronic kidney disease. And the APOL1 risk genotypes are strong genetic risk factors for kidney disease in individuals of African descent. Your diet affects kidney disease, so you got to watch that, reduce processed food and red meat. And the treatment for some genetic associated kidney disease like APOL1 nephropathy are in current clinical trials. I'd like to really thank the National Institute of Health, Boston Medical Center, Boston University for sponsoring my research. Many thanks to Philips HMO for this invitation. Thank you to my superwoman, Dr. Foluke Olaniyi George, for this invitation. Please put your questions in the chat and hold on tight for the question and answer session. Thank you.
Thank you very much, Dr. Titilayo Lori. That was quite insightful. It was also lucid. And I think I love the fact that you also started with, telling us a story, because I believe in storytelling, because quite a number of us could picture that 15-year-old boy, and it was also able to let us understand that, basically being in this part of the world, we are at a higher risk for chronic kidney disease. It's almost like having a loaded gun and pointing it at someone, where the only thing is basically just pulling the trigger. We need to pay very close attention to how much we actually, because there's also something that you said that, caught my attention, where we live, where we work, where we play, there is some sort of interaction between our genes and, our lifestyle choices. And especially in this part of the world, we need to be very, very, very careful. We keep talking about, the rates for kidney diseases have been increasing, especially in this part of the world. I'm talking about Twitter. Sometimes you go to Twitter and everybody's saying, someone they know just had kidney failure. And we keep pointing fingers at so many things, which, rightfully are risk factors, but making this genetic connection, makes it a lot clearer that we need to be more careful. This is also going to help advocates like us, still push this particular information forward. Thank you very much for your work. Thank you so much for making it clearer for us. Remember, if you're part of this session, you have to put your questions in the comment section. We will get back to you. I can see some questions already, and it's I need to put them. Yes, thank you. I need to take these questions very, very important. We have some other speakers. Remember, there's going to be a giveaway at the end. So better pay attention, or you are hearing things like risk factors for chronic kidney disease. You're hearing, better pay attention of those things. I'm giving you people expo now. A proclamation. Expo is coming. So we have other speakers who are lined up. Remember that the idea of this particular webinar was to take us from prevention down to transplantation. And our next speaker is someone I actually hold in very deep, respect. Is more like my elder brother, Egbon. It's what I call him. Dr. Ibokwe Martin is going to speak to us, the second speaker. I'm sure he has come loaded with information, especially coming from his line of work. Doctor, it's a pleasure to have you, but I'm sure some of you want to know who Dr. Ibokwe Martin is, and we have something to share with you in order to get prepared for him. Right before that, I sort of got ahead of myself. No, you people should forgive me.
Martin is a consultant urologist and kidney transplant.
Yeah, sorry. So as I was saying, right before that, I sort of got excited and, just wanted to bring him in, make an vex small. There is someone from Philips HMO that want to talk to us about, the market services, what exactly Philips HMO can do for you, because it's not just, listening to this, it's also arming you with what you need, especially in topics like this. So for that, we have Femi Duduyemi, who is going to talk to us about the market services of Philips HMO. Femi, the floor is yours.
Amidst the prevailing mediocrity and protracted dereliction, rises an HMO with a clear mandate to redefine the health insurance space by pushing the boundaries of excellent service delivery to the limits. A member of the Philips Consulting Group with a vision to make healthcare available for everyone and a mission to deliver healthcare that works for you. Powered by very strong IT architecture that drives her operations and the healthcare value chain, making effectiveness and efficiency of the day. Ably ran by the finest of professionals, guaranteeing 100% customer satisfaction.
Philips HMO.
Thank you very much. So please confirm if you could see my screen.
Yes, we can now.
Thank you very much, Apoko Doctor. And I'd like to say thank you to every one of us for joining us this afternoon. I will just do a quick, give us a quick information about Philips HMO, and then we'll go right back to the main business of the day. I just want to tell you 1 minute why Philips HMO should be your most preferred HMO in Nigeria. Philips HMO actually came into the scene from the backdrop of a lot of challenges that have been noticed in the industry, and a lot of so many issues that HMOs have been having, and question of quality, question of delivery, question of integrity, and a lot of things that have to do with issues between HMOs and the provider, which are the hospitals. So based on this, Philips HMO actually went into a research to be able to see that is quality synonymous to some sectors alone? Is quality, can it not be found in other industries like the healthcare sector? And based on all of this, Philips HMO had a lot of solutions to many of those challenges that have been seen over the years. And quickly, Philips HMO was able to come up with a lot of innovations, IT infrastructure to make this, because we call it HMO in your pocket. And quickly, Philips HMO has over 10 different products that you think that actually based on your medical needs and your budget. We have the private health insurance plan. We have the school health, secondary, primary, or preschool. We have tertiary institution T-SHIP. Also, we have social health insurance scheme under the NHIS. We have the third-party health administration plan based on organizations that want something that is a lot bigger and wider than the scope of an HMO service. We have medical screenings, pre-employment, food and last tests, preschool screenings. Maybe you are getting a job for the first time. We have a lot of clients that are actually working with us based on these services. We have international health insurance and agricultural plan that is something that goes beyond Nigeria when you're already thinking about something beyond the four walls of this country. Then in case you have organizations that are a little bit far from where we could have hospitals and the rest, then we have what we call work site management, clinic manager system that will set up clinics for you where your staff can have access to it without actually, all emergencies and some primary care services also can always be handled at that particular level. Then we have also community-based social health insurance program. And then definitely this is for a set of people in a community. It could be something that you could, a politician would want to have a plan for a particular set of people in a locality. Community-based health insurance can always take care of this also. We have, somebody might ask me, okay, are you talking about only when I work with an organization or when I work, when I'm with a particular group? No, not only that. If you want to have something for yourself and your family alone, we have Philips HMO retail health product also that you can buy for yourself outside of a group and outside of a particular set of people. Then we have state health insurance program. Also, we know it's actually part of what the present government is actually doing. And so definitely we could actually have it in different states. We're already in quite a few number of states in Nigeria. And then also the major cause of everything is Philips HMO is very flexible. So you could have a customized plan for yourself alone, call it bespoke plan, the one that will suit your medical need and also within your budget without stressing you at all. So Philips HMO will actually deliver this one to you. So in essence, when we are saying it, Philips HMO will be able to handle every of your medical need within the scope of your budget and also your need. Quickly, why does this one have to actually be the most preferred HMO? Because why? We came into the industry with a lot of innovations. We have a lot of value-added services in terms of pharmacy benefits, in which your every prescribed medication, if you are not able to get it from your provider, it could be brought to where you stay or your office within your convenience. Also, it could be brought to anywhere you actually want it to be brought to. Also, you can actually pick up your medications also from the nearest pharmaceutical store around your place, because we already have affiliations across Nigeria. Roaming services is one of the services that anyone could enjoy on our scheme. In other words, you are not tied to a particular provider or hospital. You can use any of our hospitals, whether you're in Lagos, you are in Abuja, you are in Makurdi, you are in Ibadan, you are in Oyo, anywhere you are in the east or the north, you could make use of all of this. We have wide range of products, just like I mentioned before, that you can actually be the one that is actually okay for you. Fee for service is one of the choicest kind of system for or HMOs. In other words, you are not being called, we are not being called at any time before you actually have access to the hospitals. That means when you get to the hospital, you are attended to ASAP. Then you have a personalized officer, people, everyone that manage your particular plan is actually at your beck and call at every point in time. And because of my time, I want to say also that you might actually want to say that you may be familiar with some of the brands, that just a few of the brands that are already with Philips HMO. And you will agree with me, many of these brands, in fact, most of these brands also pay a lot of premium quality on quality and excellence. And that these are the brands that Philips HMO have been working with over the years. I want to tell you also, many of these brands have actually started with us from the first year of Philips HMO, and they are still with us. So that's to tell you that whatever the level of your strength in terms of your business, we start with you and we grow with you. So most of the time, when we start together like this, in fact, all of the time, as we have seen, that many of these brands have trusted us and they have been with us over the years. So I want to tell you, if many of these brands are with us at this particular time, that means that there's something that Philips HMO is getting right. So I want to say today, please, if you have not made Philips HMO your preferred HMO, if you're a decision maker here today, an MD of a company, or you run your own. So I want to tell you, you can call your HR immediately and tell them to check out Philips HMO so that you know what we offer. Philips HMO actually works with you and your brand, and it does not matter. We are able to relate with you on an individual level. And in case you are not even, you are actually an evolving brand, evolving company. Also, we have what we call SME, in other words, small scale enterprise. We also grow with you. We don't have to say you have to up to 30 or 40 before you can start with us. Even as low as 5 set of staff or employees, you can actually be with us. You can contact us today send a mail to sales@philipshmo.net, and we have these numbers also that you can also call, or info@philipshmo.net or hcp@philipshmo.net. Also, we're going to have this in the chat box. You can always also copy these contact details from the chat box. Thank you very much. I want to say once again today, if you have not made Philips HMO your preferred HMO, you have been missing a lot, but it's not too late. You can always call us at the end of this meeting. Thank you very much. Enjoy the rest of the webinar. Thank you. Philips HMO, always there for you.
Amidst the prevailing mediocrity and protracted dereliction, rises an HMO with a clear mandate to redefine the health insurance space by pushing the boundaries of excellent service delivery to the limits. A member of the Philips Consulting Group with a vision to make healthcare available for everyone and a mission to deliver healthcare that works for you. Powered by very strong IT architecture that drives her operations and the healthcare value chain, making effectiveness and efficiency the order of the day. Ably ran by the finest of professionals, guaranteeing 100% customer satisfaction.
Philips HMO,
always there for you. Thank you so much for that. It's been quite an insightful conversation. Thank you for that, Femi Dudu. I mean, so you guys can see that Philips HMO is not just arming you with information on what to do. They're also arming you with the tools that you need. So if I were you, I will take advantage of this immediately as soon as I can. So I think this will be the best time to introduce Dr. Martin Ibokwe, who is, like I said earlier, you know, more like an elder brother to me, has quite some wind under his sails when it comes to kidney disease, especially in Nigeria. Remember that we're going from prevention to what? To all the way to transplantation. And, you know, Dr. Martin has done quite some work in this field. So I'm sure some of you want to know exactly who he is. And if I start to talk about him and what he has done, I might not be able to, you know, get everything in one place. So I need you to watch the next screen that's going to come up, and that will tell you almost, like I said, almost, but not all, what you need to know about Dr. Martin Ibokwe.
Dr. Ibokwe Martin is a consultant urologist and kidney transplant surgeon, and currently a clinical fellow in abdominal transplantation, Division of Kidney Transplantation, Western University, London, Ontario, Canada. He's a fellow of both the West African College of Surgeons and the National Postgraduate Medical College of Nigeria. He's an African Cancer Fellow. Martin was the head of urology at Zenith Medical and Kidney Center, Abuja, where he performed the most kidney transplant surgeries in sub-Saharan Africa with an average of 130 cases annually. He's a member of the Transplant Association of Nigeria, Nigerian Association of Urological Surgeons, Nigerian Cancer Society, and many international medical organizations. He's an avid researcher with over 50 publications in peer-reviewed national and international journals, with interest in kidney health and transplantation, endourology, uro-oncology, and andrology.
Oh, Dr. Martin Ibokwe, it will be a pleasure to listen to you. You have the floor.
Thank you very much, Nonso, for the great introduction. I will be sharing my screen shortly. I don't know whether you can see my slides.
Yes, I can.
Okay, fantastic. So thank you very much, Philips HMO, for this opportunity to continue this discussion on chronic kidney disease and kidney transplantation. I can see we have quite a lot of people here. So my name is Ibokwe Martin. I'm a urologist and a kidney transplant surgeon. And today I've been saddled with the responsibility to talk about chronic kidney diseases, understanding kidney transplantation, a global perspective. I'm excited because this talk is coming after Dr. Ilori, who is a great nephrologist who I've followed for quite a long time. And I was very happy that she laid a good background, for us to continue discussion onto the level of treatment. I have no conflict of interest, and I want to acknowledge Philips HMO for this opportunity. So I'll give this talk under the outline. I'll just talk a bit about the scourge of kidney disease, which Dr. Ilori has elaborated on. We'll talk about the kidney transplantation as an introduction. What are the benefits and the challenges? I'll talk about the global perspective and the Nigerian experience. And at the end of the talk, one of the Philip HMO executives had told me, Dr. Martin, why don't you say a thing or two about prevention, rather. And, it struck me, while we speak all the big things, as we say, prevention is always better and cheaper than cure. So you can't say all these big things without saying a thing or two about prevention. And this is where the good doctor is a great expert, because he is one of the people that reaches out to the Nigerian people, to the youths, trying to educate them. So I'm so happy he's the anchor of this program, because many of the things we're saying here are things that we need to get to the grassroots, in order to change the current narrative. So chronic kidney disease is defined as irreversible attrition of nephrons. What this means is that when the nephrons, which are the basic cells in the kidneys, begin to get destroyed, they are unable to recover when we say it's chronic kidney disease. Many times patients walk into my clinic or when they come for transplant, they're like, doctor, can this thing not just suddenly, go back to normal? And I tell them, for you to have been considered for transplantation, for you to have CKD, we must have told you that there is an irreversible destruction of the kidney. It's never going to come back to normal. And this is why you are here. So it's good to understand where you are so that we cannot get the perspective on where we need to go. So in the last decade, last couple of decades, there has been a significant rise in the number of patients who have kidney failure. And this is not surprising because as you heard about the APOL1 gene, this is a genetic defect which predisposes the Black man, especially those of us from Sub-Saharan Africa, from developing kidney disease. Also, there's a high incidence of hypertension and diabetes. During our training, we used to see lots of elderly people coming with this disease, but now we see that the age, is a lot less, either because we are looking out more, there are more health facilities, and also because of the change in the lifestyle, of our people. We are more urbanized, sedentary lifestyle, lots of obesity. Our diet is now, lots of junk food instead of what it used to be. So chronic kidney disease is staged from 1 to 5, with 1 being, very mild and 5 being end-stage renal disease, at which point the individual's kidneys no longer function and he will require maintenance hemodialysis or some form of dialysis to survive. So at the latter stages of kidney failure, the options of treatment are what we call renal replacement therapy. And this could be either from dialysis, which can be hemodialysis or peritoneal dialysis, or transplantation. Transplantation is the most preferred, modality for renal replacement therapy all over the world. This is because it has lots of advantages compared to other forms of renal replacement therapy. All right. In the United States of America, the United Network for Organ Sharing reported that in America, in 2022, there was, a significant rise in the number of 3.4% rise compared to 2021, which means that more transplantations are being performed. Of course, this still doesn't meet up with the number of patients who have chronic kidney disease and end-stage renal disease who require transplant, but it shows you the numbers. We are a lot more far behind in Nigeria, I would say. But despite being far behind, a lot of steps have been made in the right direction. For instance, in 2013, one of my teachers, Professor Arugundade in Ife, had reported, about an average of about 50 kidney transplants performed annually in Nigeria, across the country. But given 10 years from then, as of 2023, in Zenith Medical and Kidney Center, where I work, we performed an average of 130 to 150 kidney transplants annually, just in our center. Given it's, so in Nigeria, we are doing over 200 kidney transplants annually. This is a rapid improvement from what it used to be, but certainly not enough, considering the fact that we have a teeming number of people who require, kidney transplantation and other forms of renal replacement therapy, and don't have anywhere to get these services. It's also important to note that there is always going to be a mismatch between the number of people who require kidney transplantation and the donors. It's important to know that what kidney transplantation generally means is that after elaborate preparation, the doctors identify somebody, the son, daughter, brother, sister, father, mother, cousin, relative, or an altruistic donor who has a good match with the patient who has kidney failure. They have to have a good match because we do their blood grouping to make sure that they are compatible blood groups. We want to do their HLA, which is a human leukocyte antigen, to make sure that they are well matched, at least a 2/6 match. Now, we also want to do their donor-specific antibody titers to find out, to make sure that they are compatible. So when we find this kind of individual, we do all that we need to do, counseling, various levels of counseling, legal processes, etc. We actually, in surgery, we take the kidney from the healthy individual, we put it or install it into the individual who has end-stage renal disease. This kidney is supposed to take over the function of the failed kidneys in that person's body and, gives the person, a new lease of life. And the patient no more requires hemodialysis. They add weight again. They begin to have normal blood levels. They begin to have, they go back to as close to normal as possible. But there's a caveat. The caveat is that for this individual to live this normal life, he had to be on certain medications for life. These are drugs that we call anti-rejection drugs. This is because the natural mechanism of the body will be for the body to reject the new kidney that we put, because he's not the owner of that kidney. But with the use of these drugs, which we call anti-rejection medications, the body does not fight the kidney. It kind of suppresses the immunity of the individual taking it so that his body does not identify the new kidney as foreign, and it can function optimally and serve him for a long time. The average lifespan of a transplanted kidney is about 10 to 15 years. It can be a lot longer, it can be shorter as well. So this is important information. So what do we do at the workup? It's important to note that when we get the patient, the recipient, and he comes with his potential donor, transplantation is not just like any other surgery. It's a surgery that you have lots of ethical backup, so you must be sure that the donor is healthy, medically fit to go undergo surgery and to donate their kidneys. You have to ensure that socially they are stable. This means this is not an individual who doesn't have a job, who is likely to be looking for money from the recipient. This has to be evaluated. You have to make sure that psychologically they are in a good space. Many times you may see people who bring a relative who is mentally unstable, someone who cannot even give consent, someone who may have had, cerebral, asphyxia at birth, someone who may have, Down syndrome or something like that. Whenever the patient is not psychologically stable enough, or someone who is a drug addict, who, takes lots of illicit drugs and can't give a clear consent, then such an individual, should not donate their organs. And then, of course, the legal framework, because all the patients have to go to the courts, to ensure that, there are no underhand, things going on. As mentioned from the Istanbul Declaration, there are concepts of organ trafficking, pay for organs and things like that, which are grossly discouraged. I'm going to talk a bit about the Istanbul Declaration. I'm going to also talk about the standing of the National or Nigerian Health Act, on this subject. So when all this is sorted out, then we go to surgery, for the donors. What of the recipients? The recipients are sick people. They are people who have kidney failure, as you know, and so you have to evaluate thoroughly. One, you want to identify the cause of the kidney failure. Like Dr. Lorraine has spoken about hypertension, diabetes, HIV, LAPO1 gene issues, and all that. Or things like FSGS. You want to identify the cause. Patients may have obstructive, nephropathy from things like stones, strictures, prostate disease, etc. Those that have autosomal dominant polycystic kidney disease, you want to identify the etiology, because the cause of the kidney failure has a lot of impact on what you're going to do. Some patients may require some other forms of care before they come for transplant. Some people require some types of surgery before they come for transplant. And then after transplantation, that etiology will guide you on what are the things you need to do to ensure that they live a fairly stable and healthy life afterwards. So we work them up meticulously to ensure that they are stable and fit enough for surgery, because some of them might be very weak, very sick. You may have to optimize them with proper hemodialysis sessions, blood transfusions, etc., as the case may be. And then surgery, we want to prepare the bed where to lay the kidney before we put in the kidney. So as I mentioned about ethical considerations, in 2008, a lot of experts and stakeholders in transplantation met at Istanbul, Turkey, to discuss, about organ transplantation. The year prior to that, in 2007, about in Pakistan, out of about 2,000 kidney transplants that were performed in Pakistan the year before that, about 80% of them were performed on foreigners, which meant that people were coming from other countries to Pakistan to have transplant. Why? Because they were looking at local donors in Pakistan who were poor and who were being, who could be given little funds, and they would donate their kidneys. So where the world stands on the ethics of transplant is that the donor, the vulnerable, are to be protected. We saw this from the current, from the recent case that we had in the UK for one of our big politicians. The vulnerable are always to be protected. So what this means is that you must ensure in your program that there are no people that are being exploited, either from poverty or coercion or anything like this. So this is the standard of the world in transplantation. And the Nigerian Health Act, also has a chapter on this. If you go to the National Health Act from around chapter 48 to about 56, it spoke on organ donation and mentioned that nobody is to be coerced, or paid to donate their organ. And if such is found, the person is liable to a jail time, or a fine of about R1 million. This, has been there for a while. We are looking and pushing for there to be modifications in the Health Act to meet, the current, demands in the world at the moment, because it needs to be a lot more elaborate, especially now that we are beginning to have high number, of kidney failure patients and high number of transplantation, done in Nigeria. So to show, so on the left of the screen, if you look, you're going to see a kidney which I had just removed from a donor, and you can see the artery there, and that is the renal vein, as you can see from the video. Renal and the gonadal veins are always tied on the left side. You can see the ureter, the pipe that carries urine, and then you can see the big kidney there. Great. And on the right of the screen, you can see one of the publications, that we've made from Zeni Medical and Kidney Center on this topic. Here you see myself and my team. On the left side, myself with Dr. Abu, performing a donor nephrectomy. This is at the end of the operation, where we clamp the kidney, from the body and cut it out, put inside the ice slush to keep it cool, perfuse it there before we prepare it and take to the other theater to implant into the recipient. So you're going to see me cutting out the kidney now after meticulously dissecting that kidney for about an hour. So there you can see the kidney in ice in that video. And on the right here, that was me stitching in the kidney with Professor Sani Al-Hassan, on one of the transplants. In this situation, it was actually the son of this man who donated the kidney to his father. And I can tell you that, both patient and recipient were doing fine. So what are the benefits of kidney transplantation? Why kidney transplantation? We found out that kidney transplantation worldwide is more cost effective than dialysis. Because from the study performed at Zenith Hospital, when we looked at the cost implications, for a patient who has dialysis for 2 years, kidney transplantation already is cheaper, because for dialysis to be going on, you need to have about 3 sessions of dialysis. As Dr. Larry was saying, the average cost of dialysis is about 30,000, 40,000 naira per session, not dollars, as she was saying, it's naira. So, and of course, with the devaluation, I'm sure these things are going to rise. 3 sessions, per week. And there are other things that need to be done during the dialysis. Sometimes you need to have erythropoietin to ensure that their blood levels are higher, iron and things like this. So having this consistently, for about 2 years, you realize that kidney transplantation is cheaper in that regard, because it's a one-off surgery, and then you need to take drugs. And then now talk about the fact that an average transplanted kidney can survive for 10 to 15 years. So it gives this individual a long period of time of good health without having to go to the hospital every other day, to have dialysis. Long duration, as I mentioned, durability, transplantation, when well done, it's very durable. And then quality of life. This is the one that you can't even attribute to money, because when you see a post-transplant patient who is doing well, you can't tell the difference between them and a healthy person. They just take their drugs in the morning and the evening, just like a patient who has hypertension or something, and they are good. They can travel all over the world and keep on doing well once they go for their checkups at the right time. However, there are challenges, and the number one challenge is the paucity of donors. Everywhere in the world, kidney donors is a limiting step to transplantation. This is why in the West, like in Canada, where I am at the moment, deceased donors account for 70 to 80% of the donors. What this means is that donor pool is increased by the fact that organs can be gotten from dead people. When people have brain dead or cardiac death, we can keep the organs healthy while we take those organs and give them, like a dead person now who's brain dead. We have two kidneys. One kidney can go to two different people in two different places, and this has helped to increase the donor pool and reduce the pressure on living donors. So this is something that Nigeria should be looking towards, and I hope that in the next couple of years, we can transition into having a deceased donor program, which we don't have, and we don't even have the infrastructure for at the moment. So number two is financing. Of course, we know that this kind of major surgery is expensive. The average cost of transplantation, in our center in Nigeria, between 12 to 15 million naira. So this is not something the common man can easily pay out of pocket, when they have the need for it. So you see people having to solicit for funds all over, advertise on social media platforms just to be able to get some money. And even when they get money for the transplant, what of the follow-up? What of the drugs that they have to take, for life, so it becomes very difficult. What of the facilities and equipments? Not many places, in Nigeria have, the facilities the hospitals that have the wherewithal and the equipment to perform this kind of, high quality, highly specialized surgeries. And the personnel, skilled personnel who have the wherewithal to also perform this. And then finally, strong regulatory bodies to oversee, some of these programs and ensure that they are following international best practice standards. So these are some of the challenges that we face in Nigeria at the moment, which as the day goes by, we are getting over. So as I mentioned, the global perspective, the difference is that globally, we have a deceased organ donation program. So this has reduced the pressure on living donors, and there are stronger regulations, registries whereby every transplant performed are clearly and well recorded, so that, we can have follow-up for these patients and know how they are doing. And, we can have very good data coming out of the countries. So as I mentioned, in Nigeria, there's improvements every year. Currently, it's not like what it used to be. We have 100% living donor program, which is something that we need to look at, because once deceased donor programs come on board, that reduces the pressure on living people to donate their kidneys and, improves, the transplant program generally. We need to look more to our regulations to ensure that, the vulnerable are protected. As I said, it's still unaffordable to majority of the population. So health insurance and things like this need to come better for our people to be able to cover things like kidney transplantation. Centers who have the facilities and the personnel are very few. So there's such a high waiting list with very few centers to undertake this. So people, we have reduced medical tourism, outbound medical tourism to a large extent, but still many people go abroad because, the centers are still not as many to cope with the numbers that we need. So there is definitely massive room for improvement. What of prevention? I'll say just a slide on prevention. And primary prevention, diet. It's good to stay on healthy diet like fruits and vegetables, lots of water, like our doctor would say, drink water. Man, you cannot overemphasize the need for, staying well hydrated. In a country like Nigeria that is tropical, there's lots of sun and heat. So your water, your intake is gonna be more than someone who is in the temperate regions. Okay, so that is why we expect adults to take at least 2.5, liters of water, 2 liters of water per day. What of exercise? And as part of the diet, you also want to avoid industrialized foods, fried foods, all the fizzy drinks, these soft drinks that contain lots of carbonated stuff and sugars. You avoid them. Stay more of water and natural juices. Exercise. Fitness is so key. Dynamic exercises like jogging, swimming, the treadmill, exercises help in circulation and blood flow all over the body. So this goes a long way in reducing hypertension, diabetes, and improving on your kidney health. Avoiding dangerous habits like smoking. Now we see young people smoking all sorts. It's now a thing of pride and peer stuff. Shisha, marijuana. Avoid all this. They have nothing good to contribute. Okay, use of NSAIDs, these are painkillers taken over the counter. Avoid them. Herbal concoctions, illicit drug use, you should avoid. Okay, secondary prevention is when they already have the pre-morbid conditions, things like hypertension and diabetes. So you have to manage this meticulously. People go over the counter to just take drugs of blood pressure. No, there are cardiologists, there are specialists in the hospitals to see you, to look at your heart, to give you the right medication to remodel your heart and make sure that you do not progress to chronic kidney disease and end-stage renal disease, as the case may be. High blood pressure, diabetes, this can be managed safely in the hands of the expert and slow down progress, to kidney failure. Okay, so this can be done. Tertiary prevention. When the patient already has kidney failure, you have to present yourself to the right specialist. In Nigeria, people will go to the churches and the mosques at first, or to the farm, or to the chemists, and waste all sorts of time, and they come at a stage where nothing much can be done. So this is what we hope that this kind of a program can help to enlighten our people so that we can change the narrative. In conclusion, there's an enormous burden of chronic kidney disease worldwide, especially in sub-Saharan Africa. Most of these patients will progress to end-stage renal disease. Transplantation still remains the best option of treatment. There are challenges with transplantation, but we are happy that at this time there is improved skill and knowledge, even in Nigeria, to perform this kind of surgery. Thank you very much.
Thank you very, very much, Dr. Martin Ibokwe. I am sure that some of us have, I can see hands being raised already. Don't worry, we will get to all your questions when it's time to get there. Dr. Martin, thank you. Thank you. This was quite a wonderful session. I also liked the fact that you showed us that it is possible. There is quite some work to be done, which you mentioned. We have massive improvement that can be done, but I think what's most important for me is the fact that it's possible. If it's possible here, then it means that we can start to work on what's possible. Thank you for people like you who are, I still think it's safe to say, you people are still front runners, especially when it comes to things like this, because yes, there is work, but the courage and the grind and the grit it takes to keep doing work like this, especially in a country with so much difficulty like Nigeria. Thank you. You also mentioned something that really caught my attention. The dead donor program really needs to take roots, especially in this country, and it will need to challenge a lot of social and cultural mindsets, because there's ones you want to take from a dead body. No, some people are going to quote certain books and tell you that we came from dust and we're going back to dust. So let us preserve the same way that we came. There are issues, but I'm sure with your help, with advocacy, with so many things, we can get to at least some level of growth. There are some questions, but I think we will just take everything at once, and then we listen to our host, which is Phillips HMO, one more time before we ask the general questions and answers. Dr. Ilori, I think this question is for you. The person, I think, is Margaret Achibong. She said, "Thank you, Dr. Ilori, for a very, very insightful session. My question is it advisable to do genetic testing to identify if one has the APOL1 variant, like one would do for BRCA genes in breast cancer?"
Thank you, Margaret. I think that's a very interesting question. So the jury is still out on genetic testing for APOL1. It's not funded by insurance in many places because we do not know for sure what to do when we get the results of this genetic testing. So if you know that you have the 2 high-risk alleles, what do you do? It's not clear. And so putting people through that heartache is one school of thought. Like, why would you, if there's nothing to be done? I think now with the advent of enalaxapine, and if the clinical trials come through and it's FDA approved, I think there may be more a case for genetic testing. A lot of us APOL1 researchers are in favor of genetic testing, just so that right? Like, I think the information is important. I think the other thing is that it's crucial is know your risk, know your family history, know your, did someone's father have kidney disease? Did their family have a high risk of hypertension? So know the risk factor for kidney disease and know the risk factors for kidney disease risk factors as well, so that you can monitor, am I, developing hypertension, is diabetes. And I know, we like, confessing positively, not, like not burdening ourselves with something if it's not there. But I guess that if there was a realization that I may have the 2 risk alleles, maybe I wouldn't eat that hamburger or pizza, maybe my behavior would be a little different and the consciousness. But I think generally, if there's a family history of kidney disease, if there's a family history of hypertension, if there's a family history of diabetes, you also need to realize that and start making lifestyle adjustments, which are the most difficult to make.
Thank you. Thank you so much for that. I think knowing for the sake of knowing would actually help quite a number of us. Probably it will solve more problems than it will create, I think. We have another question, but I think I would direct this question to Dr. Martin. Doctor, someone is asking, I think it's Olufemi Shilon. The person said, can kidney disease lead to prostate cancer or vice versa? So what the person is saying, can you get prostate cancer from kidney disease, and can you get kidney disease from prostate cancer? So,
okay, no, kidney disease cannot cause prostate cancer. However, prostate cancer can be a cause of kidney disease or kidney failure. If you know the anatomy, the kidneys are up there, they produce urine. Urine flows down through the ureters into the bladder. When you want to pass urine, go to the toilet, it flows out, right? The prostate is a gland at the neck of the bladder in men, okay, that produces prostatic fluid necessary for, procreation and things like that. So when a man gets to 40 and above, the prostate can start to get enlarged. Then some of the changes that can occur, they can cause cancer. So in instances, advanced prostate cancer can obstruct where urine flows from. So when urine is not flowing out from the kidney, well, just like a blood gutter, the urine can flow back upwards and cause what we call obstructive nephropathy and start to destroy the kidneys. Another way this can happen is advanced prostate cancer can invade the ureters. The tubes that carry urine down can be invaded by prostate cancer and obstruct them as well. So we see this from time to time. So patients will come with obstruction. Urine just does not find its way out. So prostate cancer can be a cause of kidney failure.
Thank you. Thank you very much for that. One last question because of time. I think I will direct this question to Dr. Titilaris. Someone is asking, I think, someone is asking, it says, does poverty increase the risk of chronic kidney disease? You know, you share quite a number of risk factors for, but I want to know if poverty is a risk factor on its own.
I haven't seen the data in Africa. I think there's some data I'm currently analyzing, and we'll have very specific, even amount of like the measure of the risk. But I can assure you, in many countries, poverty increases the risk of kidney disease. So it's related to the socioeconomic status. It's related to the educational achievement, you know, the level of educational achievement. And I think there are some data, but I think we're going to have data on maybe almost 8,000 individuals shortly. But I have no doubt that socioeconomic factors are very associated with kidney disease and kidney disease progression.
Okay, thank you. I think this is the best way to spend my today's Thursday. I think the best way to spend my Thursday afternoon learning about chronic kidney diseases, especially when it comes to prevention all the way to transplantation. There are quite some key factors, and we'll get to our question and answer session. But before we do that, we need to listen to our host, Philip HMO. They have something lined up for us. And so at this point, let us pay very close attention. Remember, Philip's HMO brought up this particular webinar, which Dr. Folu called the webinar of all webinars, and I think is living up to that particular title, where we've learned so much. You know, we've learned so much. I think everybody who is on this particular webinar needs to go back and reassess our lifestyle changes, reassess our risk factors, you know, ask questions, family history, especially family history. Many times we just assume that, you know, it won't happen to us, or it's something that is just for the older people. Sometimes knowing your family history can help save you from quite a lot of problems. So this will be a perfect time. Remember, after the message from our host, Philip's HMO, we would go to our question and answer session, where I would be the one asking the questions now, and people are going to win prizes. So Philip's HMO.
Amidst the prevailing mediocrity and protracted dereliction, rises an HMO with a clear mandate to redefine the health insurance space by pushing the boundaries of excellent service delivery to the limits. A member of the Philips Consulting Group with a vision to make healthcare available for everyone and a mission to deliver healthcare that works for you. Powered by very strong IT architecture that drives her operations and the healthcare value chain, making effectiveness and efficiency the order of the day. Ably ran by the finest of professionals, guaranteeing 100% customer satisfaction.
Philips HMO,
always there for you.
I like that tagline, Philips HMO, always there for you. And this is the point where we're going to ask our questions. So if you're in the comment chat section, if you're watching from YouTube, from Facebook rather, please get ready for those questions. I will ask them as often as possible so that everyone can hear. Question number 1. Name 3 risk factors for chronic kidney disease. I will keep my questions as easy as possible so that, you know, they will not say I'm doing a drill. Name 3 factors for chronic kidney disease. So the first set of people to first of all name the risk factors accurately, because it's not just by answering first, it's also by answering accurately. So what are the 3 factors that you can remember about chronic kidney disease? I can see some answers already dropping in. Don't send us direct message to me, or put it on the chat group. Put it on the chat group so that others can learn. Okay, I can see. What do you stand to win? You stand to win, number 1, data, and then some people will also win. So I'll give some time for some people to get that. Some people would also win one person actually is going to win a HMO plan from Philips HMO. So, the chat is not open to everyone. Just put it on the chat box. If you're on Facebook, put it on the comment section on Facebook. 3 risk factors for kidney disease. 3 risk factors for kidney disease. The second question is, what is the gene? Should I make it a little bit harder? Yes. On what chromosome is the ApoL1 gene? On what chromosome is the ApoL1 gene? On which particular chromosome is that gene? I know this is it's a more technical question than the other one, but I like that. Is to expose the people that were paying attention. I can see some people already rushing to answer. That's good. And then the last question. Should I make this one harder, or should I make it easier? Remember, there's still chance. Once we ask the next question, everybody can go. And the last question will not be probably from what has been said, but it will mean you to have to go to do your own research. The last question is this: name 3 functions of the kidney. Remember, this one is simple. So the first set of people to get this particular questions accurately will either win 10 gig of data or win a HMO plan from Philips HMO. So as you can see, I'm fair, so that Amaka and Nkechi will not come and block me somewhere and say, the question 1 is on what? Okay. Rosalind emoji, I don't think you got the questions correctly. So there are 3 questions already. The first one is name 3 risk factors for chronic kidney disease. Number 2, on what chromosome is the ApoL1 gene located? And last but not the least is name 3 functions of the kidney. And good luck to everyone involved. So we're getting to the end. We're getting to the end of this particular webinar that Dr. Fulu rightly called the webinar of all webinars. If you can, put all your questions and answers in one particular box. So question 1, answer, question 2, answer, question 3, so that it's easier to know who got them accurately and reach out to you. So keep commenting, keep commenting, keep commenting. Don't say I've written before. Keep writing the answers to those questions down and be sure that they are correct. We need to call on the Managing Director of Philips HMO, Dr. Victor Benebo to give us some comments, some words, explain to us exactly what we're doing here and what we stand to benefit. And so before that, there will be, like our practice is, some particular screen. So just look at the screen for you to know exactly who he is and why he's talking to us. And thank you very much. Thank you very much. Dr. Victor, you have the floor.
Thank you so very much, Doctor. You've done a great job today. And my job is very simple, is to first appreciate the whole team for this webinar of all webinars. To particularly appreciate all the attendees. I'm sure we've gotten a lot of value out of this. Special thanks to our erudite speakers, Dr. Ilori and Dr. Martin. You've done a very great justice to the topic, and I think we've learned so much. I believe everybody's taking up something today. This Health Watch 2.0 is not the end of such seminars or webinars that will be coming up. We just want to encourage you to keep connected to Philips, and you will see more and more of these value-added products will be churning out. Philips HMO, as been said earlier, is from the Philips Group, and the Philips Group is known for first-class service quality. We have a culture of excellence, and that is what we've also demonstrated in the HMO space. Of course, there are very major issues that we saw in the industry that we came to correct and to make a difference. We are actually contributing to improving the health of the population in Nigeria and actually in Africa. And we are saying that we are doing this in a way that shows care to our release, and we're very, very empathetic and very, very flexible. It will be my honor today to also welcome our chairman in the person of Felicia Phillips. So we are so grateful to you for being part of this. I will just lead in to say a few things as part of remarks for this event. He's been a very visionary and I would say strategic leader, people developer, and of course, somebody who has been contributing to national growth, national leadership, and economic development in the country and beyond, actually. So I would say at this point, it's my singular honor to welcome our chairman in the person of Felicia Phillips. Thank you so much, sir.
Well, thank you very much, Victor. And let me thank everybody for joining us this webinar, which I also found extremely interesting. I have a cousin who is a nephrologist at St. Nicholas Hospital, Dr. Ebubangwe, and I know that he's done hundreds of these kidney transplants. So I'm quite sort of familiar because we've talked about this a few times. But then again, Dr. Titi Lori and Dr. Iboku Martin, and even our Provo doctor, thank you so much for the presentations you made and the anchoring of this program. What I just want to say very quickly is that health is becoming extremely important in our country today. It's becoming very, very relevant. It's a multi-billion-dollar naira business, and I say business in terms of the amount of investment that has got to be made and the amount of research that goes on so that we can all live healthy lives. And what is even so clear, you take a country like the United States, so much is spent on healthcare in the whole ecosystem of healthcare. And I think in Nigeria, we are moving towards that. A lot of very, very large, interesting, adventurous, and new health institutions are being built. They're turning up in large numbers. People are paying more and more attention to quality health. I think, again, there was this rude awakening by COVID, whereby we're all paying more attention to how we can manage public health, personal health. And one very important factor to that is the health insurance scheme, which allows one to insure against this risk of bad health and therefore be secure in knowing that if anything does happen, you are covered for it. And this is where we sort of stepped in. Yes, the Philips Consulting Group, we've been involved in helping organizations to run their business in an operationally efficient way. And now it's like a case of putting your money where your mouth is, whereby we're saying, look, the operations management skills that we teach others, let's make use of it. And so we ended up setting up Philips Outsourcing, whereby we're outsourcing and managing people of about 7,000. And there's a whole operational challenge of getting these things done, people paid, their health taken care of, their pension taken care of, and ensuring that these things are done every month on behalf of our clients. And that gave a natural birth to our health management operations as well, where again, it's a case of how can we run this service in a very efficient way, because we're good at running these things. And so we've linked with great service providers, great top medical institutions in this country, and they're increasing in number. We've put in place good operational processes, especially technology-driven processes that makes it possible to onboard people and make sure that the service is provided and monitoring the quality of it thereafter. And then obviously the most important part, being able to pay these providers, because you find that that's always a major issue. The service providers, the doctors and hospitals and institutions of that nature, they need to be paid so they can fund their own operations and even provide further investments. And being part of this value chain and being a very efficient one is something that we're very proud of. We're a national HMO, which means that we're operating in all parts of the whole country. So I think that we're proud of what we do, and I just want to take this opportunity to congratulate Dr. Benebo and his team for a wonderful thing they're doing within the group and for making us very, very proud. We are continuously, shall I say, courted by hospitals, increasingly so, because they realize that we've been very efficient in the manner in which we deal with them, paying them on time, monitoring their quality, and even the whole, like I said, value chain, the pharmaceutical companies, the pharmacies, doctors, nurses, and everybody in that medical family. So once again, thank you for participating in this. This is 2.0. We shall have 3.0 and 4 and many, many more, dealing with the different things that we feel will be useful to you to help you to maintain a good and healthy lifestyle, and also recognize that there's a huge role that we want to play in this. So once again, thank you and have a good rest of the day. Thank you.
Thank you very much, sir, for that. It's been an honor listening to you. Thank you for putting something like this together. Thank you for the team. Thank you to everyone who has been a part of this. Thank you to the participants. We had over 400 people from Facebook to Zoom to Instagram. Thank you for staying to this very point. I'm sure, just as Mr. Phillips said, that you took value away from this. I don't know about you, but I did take quite a number of value, from this. I think at some point maybe Philips should start charging for platforms like this, because it actually turned out to be the webinar of all webinars. Now I want us to do something, right? Okay, I just noticed, for those of you asking for the soft copy, Dr. Titi Lori just posted something on the chat box, so you can take advantage of that also, in case you want to have a soft copy of this particular of her particular lecture. I think that will come in handy to quite a number of people. So you can just click the download, the image download, and use that to help yourself. She dropped something about preventing chronic kidney disease, which I think is actually very important. Additional announcements will also go on WhatsApp. So the value that's been gotten here has been immense. Thank you, Phillips HMO, for putting something like this. And like I said, I want you to do something. I want everybody, if you can, we're about to have a photo session. So please, everyone, put on your video. Don't switch it off. Put on your video so that we can have a quick photo session. No matter where you are, I can see some people. Put on your photo session. Thank you, thank you, thank you. Ah, yes. I like it. Is that somebody in Lagos traffic that I can see on this call also? You're joining us from wherever you are. Love it, love it. Ah, yes. So we'll have the photo session now. Please keep it on, keep it on, keep it on. I like the beautiful faces I'm seeing. Mr. Joseph Ibilola, I can see your smile. It's very genuine. Thank you very much for joining us. Thank you. Thank you. Please keep it on, keep it on. Please, I know David Jagede is not your name. But one thing, if you've gotten value, can I just like a show of hands? Show of hands. If you've gotten value. Ah, yes, yes, I can see that. Thank you once again, Phillips HMO, for making this possible. I'm sure our photo session is over now. Thank you for being here. Hopefully we meet in the next one, and till we meet again, please keep your kidneys safe. And if you're one of the winners of our giveaways, you will be contacted by a member of the Phillips HMO team. Thank you.
Amidst the prevailing mediocrity and protracted dereliction, rises an HMO with a clear mandate to redefine the health insurance space by pushing the boundaries of excellent service delivery to the limits. A member of the Phillips Consulting Group with a vision to make healthcare available for everyone and a mission to deliver healthcare that works for you. Powered by very strong IT architecture that drives her operations and the healthcare value chain, making effectiveness and efficiency the order of the day. Ably ran by the finest of professionals, guaranteeing 100% customer satisfaction.
Phillips HMO,
always there for you.
Amidst the prevailing mediocrity and protracted dereliction, rises an HMO with a clear mandate to redefine the health insurance space by pushing the boundaries of excellent service delivery to the limits. A member of the Phillips Consulting Group with a vision to make healthcare available for everyone and a mission to deliver healthcare that works for you. Powered by very strong IT architecture that drives her operations and the healthcare value chain, making effectiveness and efficiency the order of the day. Ably ran by the finest of professionals, guaranteeing 100% customer satisfaction.
Phillips HMO,